Perfect. Good morning, ladies and gentlemen. Welcome back to our international ground rounds. Today, I'm very pleased to have another guest stars from our audience and our speakers. Welcome to Shahz Ahmed. Good morning.
Good morning or good afternoon, wherever you are.
Exactly. So today's talk is going to be focused on pituitary surgery. And especially in this field, I would like to have Shahz to talk about what's new in pituitary surgery and what are the news and the advance where we are actually and the state of the art up to date to the 2022. As usual, I request all the audience to type your questions. If you have any question, we will reply to those at the end. Shahz Ahmed is from Edinburgh. Is it correct?
Birmingham, UK.
From Birmingham, UK. And please type your questions and we will reply at the end of his talk. Please, Shahz, if you could share your screen.
Thank you again for the invitation. So I am going to share with you, I think some of it will be newish and some will be new. So let's go. I guess firstly to introduce myself, I am an ENT surgeon. I think like most of you, I'm a rhinologist, and in Birmingham in the UK, I have a separate pituitary practice as well with the neurosurgeons, but also independently. These are my disclosures. So this is where I work. So the picture on the bottom is University Hospitals Birmingham, and then at the top is an old Victorian building, and that's our children's hospital. And probably once a year, maybe once every 18 months, we get a pediatric patient with a pituitary tumor. Now, this is very much a team operation. And I think pituitary surgery really does highlight the importance of having a well-functioning supportive team. So here, this is our team in Birmingham. I'm the only ENT surgeon, and we've got two neurosurgeons, Mr. Paluzzi and Mr. Simonis. We've got neuro-ophthalmology, neuropathology. Occasionally, when our Cushing's patients do need their adrenal glands removed, we've got a dedicated laparoscopic adrenal surgeon. For our patients who are under the age of 30 with a pituitary tumor, we get genetic testing. Everything is managed in a database with an MDT coordinator. We've got a large group of endocrine nurse specialists. Those are the CNS nurses. And they really do help in managing the patients, supporting them in outpatients and on the wards. We've got dedicated anaesthetists. For our acromegaly patients, we have a go-to gastroenterologist to carry out their screening colonoscopies, respiratory physician, biochemist, and then neuroradiology. This is really, really important. The key, I mean, they're all key members, but you've got to have good, dedicated neuroradiologists. And then, of course, leading the pituitary arena is our endocrinologists, and then occasionally oncology. And we do carry out research, and we've got a biobank of pituitary tissue. So I'm going to start with just mentioning Oskar Hirsch. So Oskar Hirsch was a Viennese ENT surgeon. He's a rhinologist. And back in 1906, 1907, at about the same time as Harvey Cushing, Oskar Hirsch was also conducting the very first transsphenoidal pituitary operation. So as ENT surgeons and rhinologists, I'm really keen that we do understand that we have a really key role to play in this particular pathology, and most of the work is part of the approach. And if we get the approach right, it makes the actual surgery and the chance of success much higher. So we've got to work hand in hand, support our patients. And if your setup is with a neurosurgeon, work in that multidisciplinary fashion, because you will be able to reduce the nasal morbidity that patients have. Here on the right hand side of the screen is a chap called Alan Johnson, and he is an ENT surgeon, and he's the one that taught me pituitary surgery. So it's 2-surgeon operation. It is 2 brains as well as 4 hands and multiple feet. And you've got to remember that, so that you have a competent second surgeon. Now, anything that is complex, if you try and put structure to it, it makes it much easier to manage. So pituitary surgery is a great example. So we've got this document and we update it every couple of years. And it is our clinical guidelines on how we manage pituitary surgery. So it's got the pre-op, it's got the perioperative and the post-op guidelines. Now, nearly 100% of pituitary operations now are performed endonasally. And we like doing this because we get this great view, and our cameras and our systems are getting better and better. We've got not only now high definition, we've moved into ultra high definition, so that's 4K. And I've also used 3D, which is really interesting as well. But it's not always like this. So you've got to recognize the times when the pneumatization within the sphenoid may be such that you are not going to see that appearance, and then you might want to use navigation. So navigation is changing. We've got now augmented reality within our navigation systems. We can segment, we can mark out areas, and I would certainly encourage you to use navigation for all of your surgery. And I mentioned neuroradiology, but look at your imaging, look at the sinuses, understand the variations so that you're not surprised when you get somewhere. This, for example, is very prominent anode cells. So you've got the optic nerve sitting almost in the breeze. Nasal decongestion, absolutely essential. I do the decongestion. We have a separate anesthetic room. I use 1 in 10,000 adrenaline. I put 10 neuropathies in each side. Patient then gets wheeled from the anesthetic room into the theatre. In the theatre then, there is the setup, there's the prep, there is setting up the navigation and the whole thing. And that gives the nose more than enough time to decongest. And then I don't inject. I take the patties out and we're good to go. Let's have a look at this. So I'm going to mention the rescue pedicle. So what we want to do is, we may not use a Haddad nasoseptal flap for every case, but for every case, I do preserve a pedicle of mucosa. And what that does is I raise it with a bovie, a needle diathermy, as you can see, and then I push that mucosa down and I leave the strip of mucosa at the top. And what's my superior limit? My superior limit is the axilla of the middle turbinate and the axilla of the superior turbinate. That corresponding level on the septum, I'm not going to go above. I'm going to make sure I'm always below that, and that will help me to preserve olfaction. Now, in my consent, I always tell patients that they will have a temporary hyposmia, anosmia with some nasal crusting. And as long as I preserve that olfactory strip, then generally speaking, the sense of smell returns. Then we remove remove the rostrum, whether that be with kerosens or whether that be with a high-speed burr. And then we have here clivus, right ICA, left ICA, and I always start inferiorly. How far do I go? I go laterally up to the full blues. If I'm dealing with a pituitary adenoma that's more around one particular side, it's a NOS 3 on say the left side here, the left of the patient, then I will not only expose the full blues, which is cavernous to cavernous, inferior into cavernous sinus to superior into cavernous sinus, but I will go across and expose some of the carotid artery, and that will then help me better control the tumor excision and get a better excision. Tumor clearance, this is a different patient, but most tumors, 85 to 90% are soft and suckable, and what we want to do is try and do a complete resection. I use a combination of suction and curettes. If it's a big macroadenoma, I will debulk it first, and then I look for the pseudocapsule, and I try and very gently then dissect out the pseudocapsule. So we can see here the diaphragm is starting to descend. There's still tumor here, and what we're going to do is very gently to try and peel out some of that, but I'll demonstrate that in a moment. I mentioned the carotid artery, so I have a low threshold. If I've got, this is a left-sided NOS 3 functioning adenoma. It's an acromegaly patient, and so I'm using Doppler here to find the ICA convincingly, so that I can work around it safely. So the micro Doppler, it's a single use, the one that I use, and I would certainly encourage you to use it. Now, I put this in partly to wake you up, but also to remind myself to talk about diving surgery. And diving surgery has been initially described by Sano et al. In 2005, and then further developed by Locatelli in 2010. And I've been using it in pituitary surgery since 2018. And what I do is I use an irrigation sheath on my endoscope. And with diving surgery, when I have completely cleared all of the tumor, as far as I can tell, I will sometimes use an angled endoscope to have a look inside at each cavernous sinus in all the areas, and then I irrigate the cavity with warm saline. And I put my irrigation sheath on constant flow, so it's foot control. So my irrigation sheath is going constantly, and I change the focal length of my endoscope, and this is what you see. So once you've completed the surgery, then you go into the cavity and you are irrigating maybe a few cells that have been left behind, because the majority of pituitary tumors are soft and almost liquid. And so with this, as you're going in with the irrigation on the endoscope going as well, the screen wash, this will open out those areas where the diaphragms come down and collapse, and it will help to wash out those areas. And if you see a small remnant, then even underwater, one can get a small micro pituitary curette and curette that out, or with micro biopsy forceps is to remove it. So this is new if you haven't seen it before. It's very easy to incorporate in theatre, any theatre. It uses the standard irrigation sheaths, whether it's Medtronic or Storks or other companies. The warm saline helps with hemostasis as well. This data now is over a year old, but we've demonstrated that functioning tumours seem to be doing better with better outcomes. The other real new thing that I'd like to show you is ICG, so indocyanine in green video angiography. So ICG is a fluorescent dye. It's bound in plasma, so it's injected intravenously and it goes into the intravascular system, and it fluoresces green wherever there is high vasculature. It's used extensively in, certainly in my hospital, in liver surgery, in neurosurgery, and for the last few months, I've been using it within my pituitary surgery. So this is ICG. It comes as a vial that you make up with water, and then you inject intraoperatively, intravenously during the operation. And there are two phases. So immediately or within a few seconds, you see the internal carotid arteries light up. So we've got here celotomy, we've got right ICN, very obvious left ICA, still with a little bony covering. And then what you see is the adenoma. So pituitary adenomas take up less contrast. So you see the gland and you see a little area of hypofluorescence. So the vial comes as a standard 25 milligram ampule. We dilute it. There is a standard dilution. Inject it, followed by 10 mils of saline flush. And then within the first few seconds, you see the internal carotid arteries go up. So here at the beginning of this video, we've injected. I'm still gently widening my celotomy. And here within a few seconds, you can see that's left ICA and right ICA still underneath the bone. After about 4 or 5 minutes, then the contrast flushes out of the main vessels, and we can see here, this is the normal gland, and here in the left, bottom left of the patient, so bottom right of the screen, we can see a small adenoma, and this was a Cushing's patient, and so we remove this, and the patient was in remission. So open the dura, and there it is. So that's within 4 or 5 minutes of injection, and one can repeat the injection. So that's certainly something I've employed only in the recent few months. Cost effectiveness, ICG in the UK costs about £75. The ICG endoscope is the one I'm using, is made by Storks. It's approximately £700 more than the standard endoscope, and it has to have an ICG filter. So when one is using it, you will switch it over to the ICG filter. Otherwise, you can use it as a normal endoscope. And we don't have the evidence yet, but the idea is that for functioning tumours, we hope to demonstrate that remission rates are better, and for non-functioning tumours, it will demonstrate normal gland, and hopefully when we see normal gland, we're more likely to preserve it. You know, as you saw in the very first injection, within a few seconds, you can see big main vessels, the internal carotid arteries. So again, it helps to serve as showing you landmarks. A bit about CSF leaks. So CSF leaks, I started to use a little bit more fat and fascia lata and the vascularized flap maybe than I used to a couple of years ago. But most things work very well. And what one has to do is just to be very meticulous in how you're repairing it. If I'm operating on a patient with acromegaly, many of them will have obstructive sleep apnea and be CPAP users. So at the end of my surgery, I will insert bilateral nasopharyngeal airways that will bypass the sphenoid, and that's where we've been operating. And that will mean that they can use CPAP on the day of surgery. So for patients who are have obstructive sleep apnea or CPAP users, I put bilateral size 6 nasopharyngeal airways. CSF leaks. So I've certainly moved away from using lumbar drains for a post-op CSF leak, and I have a low threshold to take patients back to theatre and be meticulous in my repair techniques. I always use rescue flaps, so I've got the pedicle, usually both sides, that are available, and I pick one side, and I can use that to repair the leak. The challenge with lumbar drains is this. So this is a previous pituitary patient of mine who had a lumbar drain and then vomited and sneezed on the ward and blew air into his head. And you can see here, this is tension pneumocephalus. He needed an emergency burr hole, as well as going in transsphenoidally and plugging the leak. Nasal crusting and scabbing, we try to be more mucosal preserving. So when I do a standard transsphenoidal pituitary operation, I don't use a microdebrider. I will use a Colorado needle, so a bovine needle, to make my rescue flaps. I push the mucosa down, and then the olfactory strip, I gently push up a little bit, and then I take the 1.5 centimeter of posterior septum and the rostrum away. I don't need the debrider for that. And that certainly, if you can be more mucosal preserving, you get less crusting and less scabbing. I believe in giving patients as much information as we can, and we give them information on gentle nasal douching, as well as lots of other information. So let's talk about bleeding. So avoid it. You've got to get the right diagnosis. This is a right ICA aneurysm. We should all be able to manage small arterial bleeding. It's part of our practice in sinus surgery. Venous bleeding, if you have a cavernous bleed, again, can be relatively easily managed. Now, if you have Surgiflow or Flow Seal, we can use that. If you don't, you can gently put some Surgicel inside and pack it and wait 5 minutes, and it will always stop. If you have arterial bleeding, identify it, cauterize it, ligate it. Major arterial bleeding is internal carotid artery, and you want to avoid it. And if you do have it, you want to have a plan that you've thought out clearly in your mind, so that if it happens, you know what to do. So this is NOS3, NOS4, left-sided pituitary adenoma in an acromegalic patient. And here we were gently trying to peel the tumor, and with a avulsed tiny vessel from the internal carotid artery, and you can see it is just bleeding. This is now real time, and here there's 2 surgeons. We've immediately taken some muscle, we've morselized it, and you can see the muscle going in the contralateral side, and we're trying desperately to get control. So first thing to do is big sucker over the hole that is there, and then place a muscle patch over it. Now, we did this a few times and the muscle patch kept coming off. So this was the birth of the muscle wonton, which is morselized piece of muscle wrapped in some Surgicel. And then when you hold the end of the Surgicel, like the neck of a wonton, you can actually maneuver it. And this is it here. So we got bleeding under here, and this is that muscle wonton that's going in. And the idea is not to put tight pressure. It's just to hold over the hole so that the thrombogenic agents released by the morselized muscle will stop this bleeding and cause thrombosis. It's not to squash and occlude the artery. Patients now starting to go home at 2 days, some at 3, some 4 and 5. And we tend to use soluble, absorbable packs where we can. We give patients lots of information so that they can take away while they're in hospital. They can read and understand about their steroid, about nasal washes, about what to expect following surgery. I'm going to go through a case, so I'm going to end with this case, and this is a case that I was operating on yesterday. So this is a 28-year-old male who was diagnosed with Cushing's when he was 10 years old. He underwent transsphenoidal adenectomy at the age of 10 in another hospital. He then had pituitary radiotherapy at the age of 11, and he was still had active Cushing's, and then went on to have an adrenalectomy 3 years later at the age of 14. He was then lost to follow-up. He moved to Birmingham, and he presented to our hospital with an ACTH of 436, which is extremely high. So this is now Nelson syndrome. He was on testosterone and hydrocortisone. He's had an MRI scan, and the MRI scan shows a pituitary macroadenoma. We can see it here. We got optic nerves at the top. His vision is intact, but he's got this. Now this chap, he's 28 now, so 14 years ago he had surgery and radiotherapy. So he's actually got a lot of sclerotic bone here on the right side. It's mostly right-sided, and he needs to have revision surgery. So I'm going to show you what I did yesterday. And I used a Doppler, I used diving, I used a high-speed drill, I used ICG. So here it is. So transsphenoidal going in, and we've injected our ICG. This is after a few minutes. So the internal carotid artery only shows up within the first few seconds. Then the ICG washes out and it goes into the gland. So this is normal gland, and this bit of bone still needs to be removed. But we found in this sclerotic bone, we found the pituitary fossa, and we've started to get our anatomy. This is the micro Doppler. So I'm using the micro Doppler here, this white instrument, to try and identify where is the carotid. I like using a high-speed drill, but with lots of irrigation. And you can see here through the irrigation, it's just getting through that bone like butter. And I can start to see changes in color before I get through all of the bone. So this is a rough diamond burr, and I'm using this to thin all of that sclerotic bone away, and then I'm going to start taking it away. So this is where we started to see some gland. I expect the adenoma to be under here and the ICA to be under here as well. So very gently, we are going to widen this. So open it out. And once I've opened it out, I've identified what I believe to be the internal carotid. So again, I'm using Doppler. If we had sound, this would be boom, boom, boom. This would be confirming to me that this was the internal carotid artery. This is that ligament at the top. I think Danny Prevedello is, at least I call this Prevedello's ligament, because he described it and taught me what it was. So this shows us the junction of where the dural folds change, which is tells me my superior limit. And then once I found it, I then start to open out into the actual tumor. And you can see tumor is much lighter, takes up less contrast. Once the tumor's out, I can see here, this is diaphragm. And this here, this little film is what I was referring to, which was the pseudocapsule. So once it's out, and especially for a functioning tumor, what we want to do is very gently try and remove all of this from all the way around, which is a combination of finding that plane and using dissection, and here I'm gently teasing it out of the diaphragm. Once it's out, I will do diving. So this is the same patient now. So I irrigate. So I have a litre bag of warm saline. How warm? I like it if I can at 40, 45 degrees on a pressure bag. It's filling the nose. I've got suction and I've got my foot on my clear vision or endoscrub. So it's pushing all that tissue away as I get to it here. And then I explore the fossa, the cavity, so that if there are any remnants, any cells left behind, I can see them. I can go back in, correct them, or they wash out with this. And then closure. This patient had surgery and radiotherapy, so I'm going belt and braces here. I put in some fasciolatus, some fat, and then this is my nasoseptal flap. I am going to stop here, and whilst you think about any questions that you might have, I'm just going to do a plug for a new podcast that I'm involved with, which you're all invited to listen to. And I think many of the guests will be also on this portal as well. So thank you again for listening. I'm open to questions.
Thank you, Shahz, for your presentation. I seen Maestro Castelnuovo in your my maestro in your last presentation in regards to the podcast. So I invite everyone, of course, to listen to the podcast. Are those available in different platforms like Spotify, iTunes? Yeah, great. So if anyone interested, you can watch back this presentation, and at the end of it, you will see the how to get in there. What's the name of the podcast?
Knows How.
Knows How. So there you go. So we have different questions from the audience. The first one is coming from Brazil. Are you preferring use rongers or drills?
So I prefer using the high-speed diamond drill to thin out the bone, and then I like the Kerrison's rongeurs to do that final bit of dissection. I think that's safer. I want to try and protect the dura. So I use the high-speed drill, thin out the bone. Once I can almost see through it and I've blue-lined it, then I get the Kerrison's and I gently use the Kerrison's. So I use both.
The same questions coming from Argentina. When you have bony septae inside of sphenoid, are you using curettes or are you using drills?
So within the sphenoid, I've usually got the drill in my hand because I'm drilling the rostrum. So when I've done that, I use the same instrument because it's more efficient. So I use a high speed 4.5 mil rough diamond burr and I will just zip, zip, zip. If there's any septations, I take them all down. But good question, and you're absolutely right. You need to take all those septations down. I always like to go to the floor of the sphenoid so that if I do need a full repair with a nasoseptal flap, I have no septations. I go straight in and put the flap in.
Another question from France. The colleague is asking, what are the operative assessments like blood exams before surgery?
So if anybody wants to drop me an email, I can send you our protocol. It's just a standard protocol that our wider multidisciplinary team agreed, and we have a standard set of labs, which are the pituitary function tests. Must always have a prolactin because you don't want to be surprised and it's not a surgical tumor, because prolactinomas we would not operate on routinely. A group and save, we don't have a cross match, we have a group and save because we almost never will need a transfusion, and then a full blood count, UNEs, etc. But if anyone really wants that protocol, I'm very happy to share it.
Another question from Italy. Have you ever managed postoperative bleeding?
Yes, that was my patient with the carotid injury. It was an acromegaly post-operative bleeding. That was intraoperative. Yes, I have. And I had a patient 7 days after pituitary surgery, so was at home and must have had some kind of pseudoaneurysm, but he had a carotid bleed at home and was intubated in his house by the paramedics and then brought in to the hospital as an emergency. And he went straight to the interventional radiology suite and had embolization of the carotid.
The same question is coming from Egypt, and this colleague is asking, would you manage bleeding by only nasal packing? I'm not sure if the question is correctly placed, but I'm just referring to you what's written.
No, I think if because you've got an open cavity, you've taken the bone off. So if you just pack it, potentially the blood will carry on expanding intracranially. So I would want to stop the bleeding, unless it was a venous ooze. That's different. But if I was dealing with a carotid bleed, if I couldn't control it in theatre, absolutely right. You pack it, you go to interventional radiology, do your angiogram and try and control it. Even if you do control it, you cancel the rest of the list. You go into your IR suite and you want to get an angiogram and see if it's still leaking. So I would not manage a major arterial bleed just with packing. And even if it stopped, I'd always get an angiogram straight away.
From Portugal, what are the limits of the endoscopic assessments?
The limits of the endoscopic assessment?
I think that it will be the limits of endoscopic procedures or the endoscopic endonasal procedures.
Yeah, so actually it depends upon your abilities, the equipment you have, the anatomy of the sinuses. So sometimes, if we talk about, say, frontal sinuses, if there are really pneumatized supraorbital cells and a really big frontal sinus, you can do a lot more endonasally. You can do a transorbital approach and, come through an endonasal approach. So I think it's your own skill and experience, your equipment, the anatomy of what you're dealing with, and the biology of the tumor. Just because you can do it, it doesn't mean it's the right thing to do. And this is where working within a multidisciplinary team is really important, so that you are able to offer your patients a full choice of endonasal and external approaches where it's needed.
Cavernous sinus involvement or invasion, open approach or endonasal approach?
So
from Egypt.
Okay, so if we are talking about pituitary lesions, then if it's a soft liquid tumor, very soft, then I would do an expanded endonasal approach. I would expose both sides of the carotid, and I would very gently explore that to try and remove it from both medial and lateral to the carotid, if it was really extensive. However, if it was a firm or rubbery tumor, I wouldn't. I would debulk the central portion, and we would, consider radiotherapy or other treatment for the cavernous, because you will cause, or at least I will cause, multiple cranial nerve pulses.
From Russia, small soft tissue adenoma in a 12 years old patient with no symptoms. Would you follow up these patients, or you will straight go in the OR?
So in the absence of any symptoms, I would, as we would do in adults as well, is we would put them on active surveillance. So maybe initially another MRI scan in 6 months, and if there's no change, then even in an adult, potentially, if there's no visual dysfunction and it's a non-functioning lesion, then there isn't really a strong indication to intervene. However, if you have a 12-year-old and you scan them at 6 months and it's grown and they still have no symptoms, you have a growth rate, and you know that in another 6 or 12 months it's going to grow some more. So at some point they will definitely have to have treatment. Then I would discuss the patient within a multidisciplinary team, and I would offer surgery.
Another question from Iran, and they're asking, would you suggest nasal douching postoperatively?
So all of my patients, transsphenoidal patients, I ask them to start nasal douching gently after about 10 days. I want to give it a chance to settle, to heal. Then when they douche, the crusting, the debris comes out, the sense of smell returns much quicker, and the nose is more healthy.
Same question from Iran. If you're performing nasal douches, would you suggest the use of steroids?
Not routinely in the douche, no, because we're not dealing with inflammatory nasal disease. We are just dealing with post-op healing. I would put steroid in the douche in someone with nasal polyps, but not post-pituitary, no.
Perfect. Thanks, Shahz. I think that there's plenty other questions. We're running out of time. And would you please share once again your email if anyone has questions in regards to this topic?
Yeah, I will put it in the group chat now.
Yes. So it's shahz.ahmed@nhs.net, correct?
Correct, yeah.
Perfect, thank you. So thanks for being with us today for the presentation, of course. I hope that you can be invited once again for the next semester. I would like to take advantage of this time to remind the attendees for the upcoming meeting. It's going to be April 13, and the guest is Narayan Janakiram from India. You already know he's been plenty times guest with us, live surgery. This time he's going to be focused on mucormycosis and COVID-19. As you already aware, the fact that mucormycosis was pretty much frequent in India. So for the attendees, there are some surgical tips and surgical nuances. Thank you, Shahz, for being with us today. And I hope to see you very, very soon in the upcoming meetings.
Thank you again. It's been a pleasure.